Welcome. Glad you could join us. Welcome to our Sign Up with a Professor session for January of 2023. We welcome you. We have a great opportunity to talk today about some cervical lesions, as well as some lesions in the vagina. We'll talk about epithelial lesions and some stromal lesions. And we're very glad that you could be with us. And as I mentioned earlier, if you have questions as we go along, please feel free to type them into the chat. We'll take time as we go along or at the end to try to answer your questions. So this first slide is a cervical biopsy. And as you can see at low magnification, we have some squamous surface, we have some glands, we have some inflammation and some mucus and blood and so forth. And I want to just sort of illustrate some of the relatively normal but sometimes confusing findings that can be seen in the cervix, and use that as a comparison with some of the lesions that we will look at. So the squamous epithelium in the cervix can be both mature and somewhat immature. Now, I use the term immature metaplasia as an indicator that the cells have not yet fully developed abundant cytoplasm. So here on the right, this is more mature squamous metaplasia. Over here, we might think of this as slightly immature. And then here, even more immature would be a situation where we still have some measure of surface mucinous epithelium or glandular epithelial lining. So in some previous works, they would call this reserve cell hyperplasia or reserve cells that are becoming metaplastic squamous cells. And as you can see, there can be a degree of atypia in these cells with a little bit of nuclear enlargement, maybe a few little micronucleoli. And this change is fairly frequent. And in cytology, as well as in surgical pathology, can be the source of some confusion in terms of whether or not these cells are pre-neoplastic or dysplastic cells. And that's going to be important as we look at the next case, which is a nice example of an entity that we don't see very often, but very closely mimics this sort of benign change here that we see with a combination of mucin and some basal cells that have more squamoid features, as you see here. So with that introduction, let's go on to the next case, or this next case. Again, here you can see this is a hysterectomy specimen. We've got what looks like endocervix up here, a little bit of a polyp, and then we see this darker bluish tissue down here at the squamocolumnar junction that looks like it may be in situ neoplasia. So that is where we're going to go next. As we look at this a little higher magnification, I think you'll see why I wanted to include that earlier slide as an example. So how is this different from what we saw earlier? Here we have a columnar surface epithelium, and then we have some basal cells. And there's some proliferation of them. We've got a surface epithelium here. Well, for one thing, we see there's a little bit greater degree of hyperchromasia. We see more mitotic figures, and there's more atypia to the nuclei. So that's one feature. Then as we look up in other areas, we begin to see, some sort of glandular proliferation going even into the stroma, perhaps, in some of these areas. And we'll go up here to the surface. And here we're seeing, again, this combination of sort of basal mucinous epithelium proliferation, atypia, and some almost squamous-like features. So it's really hard here to say, is this a glandular dysplasia or is this a squamous dysplasia? What's really going on here? And that's often the case in these lesions. They're sometimes difficult to distinguish between whether they're squamous or glandular. And so here you might say, well, this looks like it's almost entirely squamous epithelium. And yet looking at another field over here, we might say, well, this looks like it's more of a glandular epithelium. We've got mucin production in this lesion. And these cells are just a little bit atypical as well. So this is an example of what is termed in the reported literature as stratified mucinous intraepithelial neoplasia, or SMILE. And so in areas it can look very conventional, like this, high-grade squamous lesion or squamous dysplasia. And in other areas it can look more like a glandular dysplasia. If you do a P16 stain or an HPV in situ hybridization, this is an HPV-related lesion. Now this is, I think in this section, almost entirely in situ. But in this patient, there was an adjacent area, which I'll show you in this next slide, where, as you can see, it's much more exophytic, and there's a variety of things going on here as well. And here, I think you would then begin to see that this is almost here entirely a mucinous neoplasia. This is, intraepithelial carcinoma. Here we have, mitoses, we have this very bizarre cells, and we have all of this mucin. So this is not conventional endocervical adenocarcinoma, because that doesn't usually produce this amount of mucin. But as we look around on this area or this lesion elsewhere, we see these more conventional areas of what is the typical description of stratified mucinous intraepithelial neoplasia, which shows here this stratification, multi-levels, and areas of mucin production. And sometimes that can be like here. Here it's much more clearly stratified, and many of these vacuoles are not squamous vacuoles, but these are mucin droplets in the cytoplasm here. So this is quite a complex picture, and can be very confusing at times if you're not aware of this entity in terms of whether to call this adenocarcinoma or adenosquamous carcinoma or something else. There is, as you can see here, an element of invasive neoplasia here. And so here we can see the tumor is invading the stroma. We've got an inflammatory response. We've got small nests of cells down in the stroma. And so there's an invasive component. And the invasive component of this lesion can be of a variety of types. It can be sort of a conventional squamous carcinoma. It can be adenocarcinoma, or it can be something that's kind of in between, more of an adenosquamous appearance with the actual mucin production as well. So there are a number of other morphologies of this that we could go into, but I wanted you to see some of the spectrum that can be seen with these stratified mucinous intraepithelial neoplasias and the accompanying invasive tumors that may develop from there. So I'll go on and compare this in the next slide with a more conventional endocervical adenocarcinoma. So here is this lesion. As you can see, it's a bit exophytic as well. It's got some extension down here into the stroma, as well as some benign Nabothean cysts. Now, as we look at these lesions, we see that the epithelial pattern is different. Here we don't see all of that mucin production that we saw on the stratified mucinous intraepithelial neoplasia. We do see the conventional features of endocervical adenocarcinoma, which is nuclear crowding, stratification. And as we look around here, we should be able to find some luminal type mitotic figures. They're usually readily identified, and I think I have some here. If I could find them. But typically with conventional endocervical adenocarcinoma, the cells sort of migrate towards the lumen as they're about to divide. And here's, I think, an example right here. There's a mitotic figure. Here's probably another one over here. And these are generally towards the surface rather than at the base of the glandular epithelium. And that's a helpful feature. Now, these lesions also are very strongly P16 positive. They're HPV related. With this lesion, it can be very difficult at times to define what is invasive. So this is really confluent. So this is confluent tumor, and we don't see a lot of desmoplastic stromal response. Now here we see tumor sort of spaced out, a little bit of stroma in between, and it's at the level of these other, benign endocervical glands. And then here also sort of continuing at that level, we see this glandular proliferation. So it's difficult here to know, is this invasive tumor, or is this just sort of a complex gland within a pre-existing gland? And because of that reason, sometimes with this tumor, if you believe it's invasion, but you're not totally clear exactly where invasion begins and ends, we would report the overall thickness of the lesion rather than a depth of invasion per se, because it can be quite difficult to ascertain. Now, there's one other feature here I want to show you on this slide as we come up here, which is more towards the endocervical canal. And that is just the comparison with ciliated or tubal metaplasia. So here are some cells here, which look a little bit atypical. There's a little bit of crowding and so forth. But as we look at these cells, I think you would be able to identify that we have these clear PEG cells that are part of ciliated metaplasia. And as we were to go along here, we would see there are very nice terminal bars along the epithelial surface. So we have a ciliated type metaplasia here. And that can be sometimes difficult to distinguish between endocervical adenocarcinoma in situ, if it's very florid or has a little bit of atypia. And the P16 stain oftentimes can be confusing because many times this tubal metaplasia will have strong areas of P16 positivity. So just here on the same slide for you to compare this ciliated metaplasia or tubal metaplasia with the endocervical adenocarcinoma here on the other side. Now, endocervical adenocarcinoma, of course, as you know, is a more concerning neoplasm. It has particularly if it's a high grade or a deeply invasive tumor, can be more difficult to eradicate. But also, this is a more difficult lesion to detect. because many times it will be the deeper glands rather than the superficial glands that will get sampled in a pap smear or otherwise. Now, I have another cervical carcinoma here for you to compare with this, which is this lesion. And this patient actually had a bulky tumor that involved the cervix, as well as the lower uterine segment and portions of the myometrium. And here we're sectioning this with a bit of myometrium involved here, but this tumor was contiguous with a tumor that was also very bulky and deeply invasive within the cervix. Now, as we looked at this tumor, this is one of the challenges in GYN pathology, is often distinguishing between cervical cancer and endometrial cancer. And since most cervical cancers are HPV related, we often will use a P16 stain to differentiate those tumors which are HPV related from those that are not. And although this tumor had a bulky cervical mass, it was P16 negative. And so many initial observers might say, well, these look like very tall columnar type cells. They look more endometrioid in many respects, because this is more of an endometrioid pattern. And so could this be endometrioid carcinoma? And this is where it's important to use more than just one or two markers to distinguish these tumors, because whereas endometrioid adenocarcinomas would be PAX8 positive and generally have strong hormonal positivity, this tumor did not. It was PAX8 negative. It was negative for hormone markers. And so then the question becomes, could this be one of the so-called gastric type cervical carcinomas that are not HPV related? And in fact, that's what this turns out to be. And this illustrates nicely the fact that these tumors are very deeply invasive. They're high-risk tumors. The survival and the treatment results from these tumors is not very good. But they can be confused with endometrial tumors. And of course, they do not respond to the conventional treatment with endometrial tumors. So these usually present in older patients, a little bit older than the usual endocervical adenocarcinomas, and more towards the age group that you would think of for endometrial tumors, but they do not have the molecular or immunophenotypic features of endometrial or endometrioid adenocarcinoma. So not everything that's P16 negative in the cervix is going to be endometrial in origin. You have to remember the possibility of the non-HPV related gastric type carcinomas and consider that as well. So there's a lot of good learning lessons on cervical adenocarcinomas. Let's just pause here. Maybe there's a question. So good question. Are there any stains to confirm the gastric type of adenocarcinoma? There's not anything that's specific for those tumors. It's more a matter of excluding conventional HPV-related adenocarcinoma and excluding endometrioid carcinomas, which can mimic them. The site of origin or the epicenter, the large bulk of the mass usually is cervical rather than endometrial, and that's helpful as well. Okay, so let's go on just to look at some of the squamous lesions. And this, I think, illustrates, what is a very common finding if you get cervical biopsies. But it also raises the question about where the appropriate threshold is for calling something dysplasia or not. So we'll just rotate this slide a little bit, sort of turn it a little bit so it looks more normal. Okay, so here's the squamocolumnar junction. And as we see here, there's a bit of nuclear disarray here. We have some clear spaces around many of these nuclei. And as we look at the nuclei, you can see some of them are slightly enlarged. They're a little bit wrinkly, and there may be a few binucleate cells here. We don't see a lot of basilar proliferation, but we do have here a suprabasilar mitotic figure. And so this nicely fits into the category of a low-grade squamous intraepithelial lesion, CIN1, mild dysplasia kind of lesion. And the spectrum in low-grade squamous lesions can be relatively broad. And so the threshold at which you make that initial diagnosis will vary somewhat. And this is why there's a little bit of inner observer variation with this diagnosis. Fortunately, in terms of the management now, we don't make a big deal about treating low-grade squamous lesions because many of these will spontaneously resolve. And they don't typically progress to high-grade lesions unless they're associated with a high-risk HPV or there's a subsequent superinfection with a high-risk HPV. But I wanted you to just see this. This is kind of a low threshold mild dysplasia, low-grade lesion. In contrast, the high-grade lesions, as we see here, typically have more hyperchromasia, more basophilia. And as you can see here, there is a loss of any sort of differentiation between the base and the superficial areas. However, that's not true of every portion of the sample. And so as you can see here over this glandular area, you get a little bit of differentiation there. And as you see here, we get a little bit more cytoplasm here. And so, you know, from a cytologic standpoint, it's obvious often the amount of cytoplasm will determine whether something is a moderate dysplasia or a mild or a severe dysplasia or high-grade lesion. But the truth is that these can be quite difficult. Now, the other feature here is that right next door here, we do have what looks like some viral cytopathic effect. You know, a little bit of perinuclear clearing, some nuclear enlargement. And so if your biopsy was just here, you might say mild dysplasia, low-grade squamous lesion. If your biopsy was this, you might think, well, this could be a little bit reactive, but right next door is the high-grade lesion. And that's not because necessarily this is progression from low to high grade. Many times these patients have multiple viral infections, and the higher risk lesions are the ones that are causing the severe dysplasia. Now, in comparison to our earlier case of stratified mucin producing intraepithelial neoplasia or SMILE, we see that the mucinous epithelium here is not neoplastic. And so there's no mucin production independently in this lesion. Okay, so we've covered that waterfront. I know that you all see those very frequently. This is something that was in the file. I'm not sure I necessarily agree with this lesion per se, but it was presented as a sort of gastric type of glandular dysplasia in situ. And as you can see here, there is a more mucin here. There is glandular crowding, but we're not getting the kind of apical mitotic figures that we would typically associate with adenocarcinoma. And so I'm not sure this is an intestinal type or gastric type of neoplasia. We do have a little more goblet type cell here, but the degree of dysplasia is not very high here in this glandular epithelium. And as I indicated before, there's not typically a stain that's useful. This was HPV or a P16 negative. So they made the presumption that this was an adenocarcinoma in situ of gastric type. And I'm not going to dwell on that because I don't think that's a great thing. Now, of course, in the vulva and vagina, these are squamous epithelia that can also be affected by the human papillomavirus and can show a spectrum of changes. So here's one where we see a little bit of papillomatosis and hyperkeratosis here. This is from the vagina and was actually part of an incidentally excised lesion. The patient had some prolapse. So here we see hyperkeratosis, more akin to kind of a condyloma. And we don't see a high degree of viral cytopathic change here. We see still an intact granular layer. So in this area, you might just be thinking, well, this may be a low-grade condyloma sort of thing. But as we come over here, we begin to see more viral cytopathic changes, more dyskaryosis, even a suggestion maybe that we have a super higher level mitosis here. We see more mitoses down at the base, more atypia. And so grading this lesion is a little bit more complicated. We go from that more purely hyperperikeratotic area to this area with a pretty clear-cut dysplasia. And I think here you'll agree that this is a mitosis. So it's a mid-level mitosis, and that certainly, I think, qualifies it as a higher grade lesion. Now I'm going to come over here a little bit further, and you'll probably be more convinced that we're dealing with a high-grade lesion because now, we've got more basilar proliferation, more mitotic activity down here. And as we come over to this other area, what looks like nearly full thickness atypia here. And so this is a high-grade lesion. I think because we still have a fair amount of cytoplasm up here, under the old system, this might still be called a vaginal intraepithelial neoplasia grade 2 or vein 2. But that's immaterial as because it's high grade, it does need obliterative therapy to salvage the patient's good prognosis while it's still an in situ lesion. So a nice contrast between degrees of dysplasia from the truly high-grade CIN3s to the more moderate level VAIN2s kind of situation, but still managed in much the same way in terms of needing to be excised or obliterated. So similar sorts of changes could be seen in the vulva, of course. So let's move now to a little bit deeper lesion. And this is a lesion that presented as a somewhat bulky submucosal mass in a woman that seemed to be kind of partially obstructing the vagina and maybe interfering a little bit with her urination, causing some polyuria. And here you can see this is a, not very cellular stromal lesion. It's got a degree of lobulation to it. You can see the sort of nodularity that's present here. And I think you can even appreciate at low magnification that there's a mixture of vessels here. So we've got some thin-walled and slightly ectatic lesions. We've got some slightly more larger vessels on occasion, as well as some very small rounded lesions. So you've got a variety of vessel types and sizes. Admixed with this fairly bland stroma. And the stroma is here primarily fibrotic. This is not a myogenic or muscular type of stroma. And I think you can see these cells are not highly atypical. And that's the pitfall with this lesion, is that it looks like a fairly low-grade lesion in the terms of cytology, maybe even a benign lesion. We don't find mitotic figures usually. And it's got this very loose, fibrous fibrillar stroma with the admixed vessels. Now, in some areas, you'll begin to appreciate there's maybe a little bit of a myxoid feature to it here. You can see a slight amount of pale blue tissue. Generally, the margins are, pushing. They're not really infiltrative to this lesion. So this is what is termed an aggressive angiomyxoma. Now, we use the term aggressive because these lesions can become quite bulky and they can recur if incompletely excised. They usually do not metastasize, but they can become large and extend very deeply from the external genitalia deeply into the pelvis. They can arise or can present as vulvar masses. Vaginal masses are somewhat more common, but they can also involve the vulva or perineum and extend up, as I mentioned, into the pelvis. Now, there are some immunostains that are felt to be useful with this. The HMGA stain, that's not something that's widely available. And so you really have to often rely on excluding other things. So this is not usually Desmond positive. It's not usually beta-catenin positive. It may have some hormonal receptors at times. And the other lesion that falls into this category or that looks somewhat like this is this next lesion that I'll show you here. So this lesion also can present as a submucosal soft tissue mass in the urogenital tract. And this is the angiomyofibroma. So notice here there's still a trace of sort of myxoid or loose tissue to this. But as you look at this lesion, I think you'll appreciate that there is definitely a more myogenic appearance to this. You can see there's more pinkness to the cytoplasm, and this lesion will have Desmond positivity. The smooth muscle tends to cluster, sort of be ball-like around the vessels. So there's some subtle differences here, but there's a lot of similarity in these two lesions that can be difficult when you're just presented with a new lesion. But if you think of Desmond positivity, again, these may be hormone positive. That's variable, and these would be HMGA negative as terms of soft tissue differential. Now, I've got a couple of other examples that I was able to pull out here from the teaching files at the University of Michigan. And so we'll present this as an unknown, as you were, on the screen. And this one has a little bit of fatty differentiation to it. As you can see, there's a little bit of fat to it. So when you think you know the diagnosis here, put it in the chat. Okay, we'll come back to those other questions a little bit later. So good question. Could this be in the PEComa category? That's a good question. Good question. As far as I know, these angiomyofibroblastomas and aggressive angiomyxoma are not in the PEComa category. They do not stain with myogenic and with melanocytic markers. So this lesion is an angiomyofibroblastoma. This one with a little bit of fat differentiation. But there's not as much myo component to this as there was in the other. Now we'll just take a look at here this other lesion here, again to give you a little bit of perspective, because this is the other lesion, an aggressive angiomyxoma. And you can see a little bit more myxoid change here. You see the variable sized vessels, and you see the very bland cytoplasm and this nice fibrillar collagenous type of stroma that can be helpful as well. I want to go on to the other couple of cases for differentiation from this as well. Whoops, this is one in. Just talk about one other lesion that maybe enters into the differential here, and that is the superficial angiomyxoma. This is a lesion that's more typically seen in the skin, but could be seen in the vulva, and therefore also enters into this differentiation. Again, note the myxoid category or character to it, the nodularity. But here, the dominant feature is the myxoid change. This lesion is not HMGA positive, it's not hormone positive, it's not Desmond positive, and it has a very prominent myxoid character to it. It doesn't have that collagenous, quite same collagenous feature. And you'll see a number of mast cells and maybe other inflammatory cells in this lesion as well as the delicate vessels that we see here. So this could be a little bit confusing for aggressive angiomyxoma, but a more superficial location, skin location associated with adnexal structure sometimes, as you see here, can present this issue or prevent you from mistaking this issue for the aggressive angiomyxoma. And both this lesion, the angiomyofibroma, and the superficial angiomyxoma only require superficial excision. They do not have the same recurrence or aggressive potential. Now, another lesion that's kind of in the differential here, and which I've done a video on earlier, is this lesion, which has usually sort of a fungiform or scalloped surface, and then this very loose stroma, which has some vessels associated with it. And usually you find in this lesion some degree of sort of funky looking or abnormal looking stromal cells. Like here we can see, there's these sort of rosette-like cells, or sort of stellate cells. So this is characteristic of the urogenital fibroepithelial stromal polyp. This is probably not different than a fibroepithelial polyp in other sites of the body. The only difference is that it has these rather distinctive and somewhat atypical or slightly bizarre stromal cells. Now, notice here also the vascularity, the way the vessels are oriented here. They're sort of oriented perpendicular to the surface as you look at them at this magnification. So you get a sense that this is almost, it has this sort of branching outward architecture. Now, you may not always see that, and so that's only useful in some settings, but it is, I think, a distinctive feature and tells you something about the way it grows. In that it has some larger vessels deeper down, and then these more capillary small vessels extending towards the surface. So at this point, I want to come back to the questions that you've raised, and that will probably take us back to some of the issues that we talked about with regard to differentiating gastric type carcinoma from endometrioid carcinoma. So the gastric type carcinomas will not be positive with PAX or PAX PAX8. Whereas endometrioid carcinoma, uniformly positive with PAX8. Additionally, endometrioid carcinomas generally tend to stain in a sort of splotchy pattern with P16. And so if you've done a P16 thinking it's cervical, and you see instead this sort of patchy, splotchy pattern, a few cells here, a few cells there, well, that's much more likely then to be endometrioid than gastric, which will usually be uniformly negative. So, Dr. Agarwal's, your answer there, very useful. Hormone markers, likewise, would be useful, positive in endometrioid carcinomas for the most part. So cervical endometrioid adenocarcinoma, that's a good question. And it's probably not particularly a crucial one in terms of therapy, because an endometrioid carcinoma occurring in the cervix is going to be treated as an endometrioid carcinoma. Now, they may still do more extensive cervical excision based on the concerns about extension and so forth. But in terms of chemotherapy, radiation therapy, and so forth, they're going to treat it as an endometrioid tumor. And again, the staining pattern will be different with the P16. The staining pattern with PAX8 and so forth will be different. Even cervical cervical endometrioid tumors will have PAX8 positivity. Okay, let's see. Any other questions down here? All right, so I think we've answered the questions. So let's, in our remaining couple of minutes here, we'll just touch on a couple of more bland, also one other lesion to be aware of in this differential in this location. This is usually presents in a much younger patient population. So this is not usually concerning with endocervical adenocarcinoma or endometrioid carcinomas. This is usually a younger patients, early adulthood, adolescence, and so forth. And this is an example of the so-called botryoid rhabdomyosarcoma. And so the gross appearance will be fairly characteristic. But what you'll see with this, of course, is some intact surface epithelium, maybe a few glands or vessels, and this very busy and hemorrhagic, poor vascular integrity in these lesions. Excuse me. Stromal proliferation with some degree of atypia. And you may or may not recognize characteristic rhabdomyogenic features on H&E. This is not one with a lot of those kind of features, although we do see some kind of strap cells here with some degree of atypia that would suggest that possibility. But doing the immunohistochemical stains for myogenin or other myeloid markers, you should be able to detect some myeloid differentiation in this lesion. So it's not usually a clinical differential problem with the other lesions that we've earlier mentioned, but for completeness, I included here for the example for you to be able to come back and look at it a little bit later. All right, well, let's just take a second or two and touch on a couple of more banal lesions that can also involve the epithelium of the vagina or the vulva. And here we see a very poorly oriented biopsy from the vagina. And as you can see here, we have a lot of lymphocytes. We have a little bit of parakeratosis here. We've got a little bit of edema and so forth. And this patient actually did have a history of cutaneous lichen planus, which was very helpful because as we look at this lesion here, we can see some of the same sorts of findings. First of all, we see a very obscured epithelial, subepithelial junction. We see a few dying keratinocytes here, apoptotic bodies or SAVAT bodies, as they may be called. We see a lot of extension of the inflammation into the epithelium, so-called exocytosis. And if this were properly oriented, we would see that this was a lichen pattern inflammatory lesion with lymphocytes and probably a few plasma cells here as well in this lesion. So this is an example of a cutaneous disorder, lichen planus, that can also involve mucous membranes, both orally and in this case in the vagina. And you see here again these dying keratinocytes, which are very characteristic of this lesion and very helpful if you can identify them. And that can help to confirm the diagnosis of lichen planus-like vaginitis. Not a very common disorder to encounter in the vagina, but in someone with that history, it would be certainly a great coup for you to be able to make that diagnosis. And finally, the other lichenoid dermatitis that can involve the vulva and vagina. You can make this diagnosis at low magnification. You can just see the pallor here. This is truly characteristic, but it can vary according to stage. So the pallor or the homogenization of the superficial dermis can be less evident. And you can occasionally get some obscuring of the dermal-epidermal junction. This is a nice example of lichen sclerosis at atrophicus. Now, this is important to distinguish between lichen sclerosis and differentiated type vulvar intraepithelial neoplasia. And we will oftentimes in these older patients do p53 stains to exclude the presence of differentiated VIN. In that situation, the basal cells will all stain in a mutated pattern, whereas the superficial cells do not. That's not the case in lichen sclerosis. So you will not get that pattern of staining with p53 in lichen sclerosis. Very good, very good. Okay, just to sort of differentiate that, another example of lichen sclerosis with less atypia, less evident lichenoid pattern. Sometimes you can actually have a very lichenoid inflammatory process in these lesions, but sometimes you'll get a poorly oriented biopsy like this, and it's just this homogenization of the dermis that allows you to make that diagnosis. In this situation, if I didn't see it well oriented, I would be somewhat suggestive. I say this is compatible with or suggestive of, and I'd probably also do the p53 stain to rule out differentiated VIN. Well, we've come to the top of the hour, and appreciate your attention and bearing with me for this. It's been great to have you with us, and we will post the recording of this as afterwards. Also, the link to the slides was in the description and will be with the video as well, so that you can study the slides on your own as well afterwards. If you like this, certainly hope you'll join us again next month. We anticipate having a guest lecturer or a guest professor to do the sign out. And the topic, I believe, is going to be on GU lesions. One of my former students and a great professor of pathology at the University of Minnesota is going to join us. And so we'll be looking forward to that presentation next month. Any final questions or comments from anyone? Well, I'm glad you're with us, and we'll look forward to seeing you again next time.